Looking at lung transplantation, so what do we know about patients' airways and lung transplantation? We know that bronchial stenosis occurs in this patient groups up to 20%. This is the majority of the benign airway disease that I am taking care of. We are at a large lung transplant center. We do anywhere from 120 to 150 lung transplants a year. We do have our 20% complication rate, and these are the patients that come to us and stay with us throughout the years because we're definitely managing these patients. We've also in the more recent years found that patients with short telomere syndrome tend to have more airway complications than other patients. This is something we retrospectively went back and looked at, that the patients that we had most airway complications with, were they actually short telomere syndrome? And they were. So almost every short telomere syndrome patient is going to get some kind of complication that needs to have some kind of intervention with them. The most common site we know is generally on the right side, is where most of their stenotic areas are occurring. Generally occurs in the first 3 to 12 months. And they have maladaptive wound healing in the setting of airway inflammation, and ischemic injury is what is setting them up for these kind of procedures. This is one of my patients. He actually is sitting here in the front row. He is from Charlotte. He drives 6 hours to come and see me, and I'm going to introduce him, who's going to come up and talk about how he felt, going through this entire process. I don't know if you've ever actually seen a video of me spraying your airway, but you're about to. So he had complications on both the right and the left side. At one point had 5 ICAS stents in place, multiple interventions he's going to talk to you about. This is me spraying the left lower lobe area. Stents are out at this point, but you can see there's a stenotic area down there. Low flow. I'm staying back, putting the probe out. You start counting the 10 seconds once about 50% of the airway is covered, and I'm leaving a lot of room for egress of gas to be able to come back around me, around the outside of the scope. So spray the entire area, you come out, wait about a minute, and you go back in. What I did find with the lung transplant population is they did need more spray therapies than what I had been doing for tracheal stenosis. For the tracheal stenosis subglottic, generally I would do about 3 treatments. I did find that I would have to go up to 5 and 6 in the transplant population, and I think that their strictures are just so thick that they need more treatments in order to be more effective as we started doing this. So we actually last year started looking at our data because we found that we were being very successful in doing this. So we had 13 lung transplant patients that we went back and looked at, and we had to go through all their charts, look at all their bronchs. A lot of them were stented, and we were doing this to try to get them stent-free. We often give them all stent-free trials. We haven't been able to get a lot of them stent-free, so we weren't able to really use that grading system. I'm looking at it because most of them had stents in when we started doing this, and so it would be hard to take a look at that. So 12 patients out of those 13 with current or prior stenting, 67% of those stents, so we had every complication you can imagine with stents, as you guys all know. 67% stent migration, 83% of them would get granulation tissue, 83% would get stent obstructions. This would result in multiple procedures we were doing trying to get these patients through the process. 8 of the patients had a stent at the time of initiation of us starting this therapy, so they had all failed, like I said, prior stent-free trials, and what we really wanted to do was see, can we get these patients stent-free? Can we do less procedures on them and span out that interval of time? So our primary outcome we looked at was the bronchoscopic intervention rate after initiating this therapy compared to prior years. And the secondary outcome was, did we get them stent-free, and what was the complication rate we were looking at? Again, all these patients were low-flow, 10-second treatments. When we looked at the prior outcome, and I couldn't do this over the year because we didn't have years worth of data, so we had to look at the number of procedures per month, and that's kind of how we looked at it. But the mean intervention rate decreased from 0.64 per month down to 0.28 per month is what we saw. 7 of the 8 patients we liberated from their stents altogether, and that was eye-opening to me. I had never been able to do that with these patients before. These were my patients. I'd bronched again and again and again. I knew their airways in and out. One patient did get restented secondary to recurrent infections, had a lot of inflammation, had to stent to help with the mucus clearance and whatnot. So one got their stent put back in, and there was 1 pneumothorax and 47 procedures that we had done. So some lessons we learned is that it's most successful in the benign population when it's used in conjunction with mechanical dilations. So even when we did spray the patients, I did do balloon dilations. Sometimes I may have had to cut the airway if it was the right main stem, if the stricture was up there, if it was lobar, balloon dilations were done on these patients. If the stricture was tight to start with, then I would dilate them first and then spray and then dilate them again. Venting can be compromised when treating distal lesions, so you need to make sure you keep your scope back, put your probe out a little further, and dilate those tight strictures prior to spraying if you are doing things in the distal BI or distal left main stem, as you saw, so that there is that egress that you're seeing. And so when we look at this all together, there are clinical benefits where you are seeing we improve airway patency. There's a regenerative healing response we're seeing that's much more gentle. It's a non-contact, easy to use, and there is hemostasis, which is actually a good thing in the malignant disease that we have.